Welcome back. Now we are going to go ahead with the next talk about high frequency ventilation combined with the volume guarantee new technology. So this is a very new kind of ventilation that we have been studying for more than 7 years from now. And I would like to introduce, this is my disclosure, what we have been doing for these last 10 to 7 years. So as you know, high frequency ventilation is a technology that can ventilate and oxygenate the lungs of any person, mostly a small baby, by keeping the lung recruit at the functional residual capacity and producing what we call variation in the pressure very fast, very low amplitude. Doing this with a very high flow in and out at a very fast frequency, you can produce very small tidal volumes, smaller than the dead space of the lung, that are going to ventilate the patient. So the philosophy is to keep the lung quiet, stop, and stable with a nice lung volume, and ventilate by inducing this oscillation into the lung by producing these small tidal volumes. So the philosophy is to use this kind of ventilation to prevent the ventilator-induced trauma. But this technique has been using for more than 30 years, and the evidence behind is that when we use this technology in very immature babies after delivery, instead of conventional ventilation, there is not any clear evidence that this technology is going to be better than standard conventional ventilation. This is the last Cochrane review from 2013, when most of the studies were comparing the effect of high frequency to conventional at the beginning after delivery in terms of death or coronary heart disease at 36 weeks post-menstrual age. And you can see that there is no clear benefit. But if you look close to this review, meta-analysis, you can see that there are two big studies done exactly at the same year, 2002. The coronary study that you can see produce a very close to benefits in terms of using high flow compared high frequency ventilation compared to the conventional. And the UK trial published as well in 2002 without any clear difference in between the two groups. But which were the difference between these two studies? So the coronary study, they used only a few different ventilators, and they were using very fast frequencies, very high rates, normally more than 12 or close to 12 hertz. That was the frequency that we're using mostly in most of the studies. But in the UK trial, most of the studies were using slower frequencies. Most of the hospitals include in the study, and they, as you can see here, this is the result of the UK trial. They didn't find any difference in the two groups. But if you go in detail to this study and you analyze well, you can see that there was a trend to be some benefits in terms of doing a little bit better with the high frequency. And the investigators, 11 to 14 years of age of these babies, they follow them and they analyze the function, the pulmonary function test, and they discovered that those babies who were in the group of high frequency ventilation at the age of 11 to 14 years were doing much better. So something behind the use of this kind of ventilation probably is going to protect the lung of the babies. Going back to the original study of the UK trial, there was a table, not in the hard copy, but the internet of the New England Journal of Medicine, that were comparing the effect over the babies when you were using different ventilators. And you can see how in the group of babies who were ventilated with a sensor medics, is a ventilator producing very large tidal volumes, very powerful ventilator. You can see how when you analyze the difference between the three groups, in this group of babies, there was a statistically significant high risk of dying or developing chronic lung disease. So probably because during those years, the technology was not very good, we didn't found any kind of benefits. From the conventional ventilation studies using the volume guarantee modality, we found and we demonstrated that this kind of modality can improve survival of the babies with less respiratory problems, and even more with less problems, neurodevelopmental problems in terms of more protection. So because of that, the possibility of use also the same volume guarantee modality during high frequency ventilation was applied to prevent the use of large tidal volumes or a variable tidal volume as well in high frequency ventilation. So this new technology was applied to the ventilators, to the high frequency ventilators, and now the possibility of controlling the tidal volume during high frequency is possible. And you set the tidal volume, and the ventilator, what it's going to do is to modify the amplitude to send exactly what tidal volume you have been setting. So we began to test 7 years ago, 7 to 10 years ago, this new modality, and I'm going to summarize very briefly what we found during those years in our studies. So here you have the standard high frequency ventilator without the volume guarantee modality. You can see the tidal volume and the frequencies. And you can see very nicely here how when you increase the frequency, you have a drop in the tidal volume. This is why for many years when you were using the high frequency ventilators, you wanted to decrease the PCO2 of the baby, you decrease the frequency, because doing that, you were increasing the tidal volume. Today, if we can fix the tidal volume with the volume guarantee modality, you can see how for any increase or decrease in the frequency, there is no change in the tidal volume. So for the very first time, now we can, as very similar to the conventional ventilation, apply a fixed tidal volume and modify the frequency to increase or decrease the efficacy on CO2 washout. So we began to test this modality, and at the beginning we test in newborn piglets with a weight around 2.7 kilogram of body weight, and in two different situations, with the normal lung and with the low compliance lung after taking out all the surfactant by a bronchoalveolar lavage. And we test the high frequency with and without the volume guarantee. So you can see here the results of the experiments. This is the PCO2, and you have the tidal volume in the previous situation with the normal lung before taking out all of the surfactant, and after with the low compliance situation. You can see how for any increase in the tidal volume, you can decrease directly PCO2. So for the very first time, now also in the volume guarantee, in the high frequency ventilation with the volume guarantee modality, you can directly apply the setting of the tidal volume to modify your PCO2. And when you decrease the compliance of the lung, you can see how the PCO2 remains stable. Because the ventilator, what we were doing is just modifying the delta P to send exactly the same tidal volume that you were setting. And as you can see, for every increase in the tidal volume, the ventilator was increasing delta P. And before and after, the ventilator was applying different changes in delta P to keep very similar tidal volume, and because of that, similar PCO2. So we wanted to test in in a lung model with CO2 infusion, the effectivity of this technique and the effect on the proximal pressure at the level of the endotracheal tube and inside the lung. So in this mock study, we analyzed applying a computer the effectivity of this modality of high frequency ventilation in terms of CO2 washout from this testing lung. So doing this, we wanted to test exactly what was happening with the pressure, and you can see in the white color, the proximal pressure, green color, the pressure at the level of the endotracheal tube, and this pink color inside the lung. Anytime we increase the frequency, the ventilator, to keep the same tidal volume, was increasing delta P. But only the delta P was increased proximal to the lung, not inside the lung. So we could demonstrate that using this modality, the delta P is not transmitted into the lung of the baby. So the baby's lung is protected against the increase of the pressure. You can see here with the volume guarantee modality, in the blue color, the proximal pressure increases every time we increase the frequency. But in the green, the pink color that represent inside the lung, there is no change in the pressure. But without the volume guarantee, what is happening? Well, it was clear that when you increase the frequency without the volume guarantee, there is a drop in the pressure, delta P, proximal and inside the lung. And this probably justifies why during so many years, most of the doctors, most of the ventilators connected to a baby on high frequency were setting around or less than 10 hertz, just to prevent this drop in delta P inside the lung. So can we target delta tidal volume and then prevent the variability of this tidal volume? And if we prevent this, can we prevent trauma to the baby's lung? Because as you know, tidal volume depends on the pulmonary situation of baby, endotracheal tube, and many other circumstances around the baby. Today, for example, we use this technology, even if the baby is skin to skin in kangaroo care, we apply the volume guarantee to prevent large variation in the tidal volume. So we wanted to test if it should be possible to apply this technology in very immature babies, and we did this study to analyze the effect of the high frequency ventilation combined with volume guarantee in very immature babies. As you can see, most of them less than 1,000 grams. What we did is we stabilized the baby when the baby was connected to the ventilator on high frequency, and then we look at the settings, and the baby were in as mean 10 hertz with the tidal volume around 2.2, and this was the FiO2 and PCO2 before. So what we did is to then fix the tidal volume in volume guarantee modality, and then try to decrease the tidal volume as much as possible and to compensate the effect on CO2 washout that is analyzed by the DCO2 will increase the frequency as much as possible. So in the before and after, we analyze the possibility of doing this new technology using very high frequency with very low tidal volume to decrease the potential trauma into the lung of the baby with large tidal volume. So what we found is that the baby were doing pretty well with a decrease, very important decrease in the tidal volume and an increase in the frequency. And the babies were even more doing better in terms of PCO2. So we moved the babies from this situation in your right-hand side of large tidal volume to smaller tidal volumes with higher frequency, and the PCO2 was kept similar in the two situations. So we could apply this technique to our very immature babies. But the clear question is that really, can we protect the lung against ventilation, this trauma, using this very low tidal volume at very high frequencies with a volume guarantee modality? So we wanted to test this hypothesis again in our animal model, newborn piglets, during 12 hours of mechanical ventilation. And we compare animals doing with standard high frequency at 10 Hertz on regular tidal volume on high frequency versus another group of animals at 20 Hertz with very, very low tidal volume. And we compare the two groups with a control group of conventional ventilation during 12 hours after producing trauma into the lung with bronchoalveolar lavage. So you can see the results of the studies. This is an electronic microscopy of the animals that were ventilating during 12 hours at 10 Hertz with regular tidal volumes, and you can see how the lung is damaged, very much damaged. But in the group of animals that were ventilated for 12 hours with 20 Hertz and very, very small tidal volumes, you can see how the microscopy, electronic microscopy of the lung was showing us that the lung was preserved very nicely. The cells were absolutely protected. And if you look at the standard microscopy in the group of standard tidal volume during 12 hours of 10 Hertz, the lung was damaged with a trauma compared to the animal's lung of the 20 Hertz during 12 hours with very small tidal volumes. Then the architecture of the lung was kept normal. And if we apply a score of damage, histological damage into these lungs, and even we compare with the control group on conventional, those animals in the 20 Hertz group were doing even much better than the conventional ventilation group. So we could demonstrate it for the very first time that this kind of technology can protect the lung of our babies. But before finishing, I want to remember you that when you have a lung, a telestatic, without surfactant, and you apply pressure to open, then you will have to increase a lot of pressure until you reach what we call the critical opening pressure. And this is a lung coming from, again, from a rat that we apply pressure from 0 to 4, 10, 20, and 13, and 30. And you can see after reaching 35, suddenly the lung is open and overdistended. So the regular thing that we used to do on high frequency is to recruit the lung. So we apply pressure to increase the lung volume, and then once the lung is open, we decrease the pressure back to keep the lung with a very good volume, good functional residual capacity without overdistension and preventing the collapse of the lung. But how we do this in clinical practice? Normally we look at the FiO2, but today we test the possibility of using the high frequency combined with a volume guarantee, looking at the delta P. So normally we recommend, as you know, to be in this safety area, but how we know that we are in here and not in this other side of the lung volume? So we did this study that has been published just a few weeks ago. And we tried to look at the change in delta P once we were recruiting the lung. And we did this in an ex vivo model, and also we repeated the study in an in vivo model in rats. So this is the ex vivo model. And as I showed you, we apply different pressure with the volume guarantee modality on high frequency. And as you can see, we came from 5 to 14, 26, 38, and you can see how the volume is very high in here and the lung is overdistended. So we analyzed the effect of the change in delta P during high frequency with the volume guarantee modality, and you can see how When we apply pressure and the lung begins to open, there is a drop in delta P until a point where no more drop in delta P appears. And this number clearly correlates with the overdistension of the lung. So in clinical, you can also look at the delta P of the ventilator to know if your baby's lung is well recruited. We did this study again in the in vivo model in the rats, and we look exactly the same, the change in delta P compared to the mean outward pressure, but now we compare this change with the oxygenation, and you can see how while we were increasing the mean outward pressure, there is an increase in SpO2 until a certain point, that no more increase in oxygenation appears. And this point clearly corresponds with the same point in the delta P decrease and represents what we call the overdistension point. So in summary, this new technology that we have the possibility to use today can fix tidal volume during high frequency, and then you can set directly the tidal volume that you want to increase or decrease the PCO2 of your babies. But also because we know that the larger is the tidal volume, the higher the risk to develop ventilation-induced trauma, we can set very, very low tidal volumes and compensate with increasing the frequency. And this technology probably is going to protect our baby's lung because you're going to decrease the risk of overdistension by some of the ventilators that are using very large tidal volume during high frequency ventilation. Of course, we have to wait until we have enough information from clinical trials, but just to summarize our experience before and after, as I told you when we began to use this technology in 2016, now these are the settings that we are using. Before we were using the frequency around 9 to 10. Now we are using a mean frequency of 15. Probably we can go up to 18 or even more. The tidal volume that we are using is much lower than before. And the duration of the settings of the mechanical ventilation is probably the same, but we have the babies less time on invasive ventilation. And of course, as I told you in the first talk, there is not only one valid to decrease the risk of bronchopulmonary dysplasia, but it's a combination of reducing the trauma into the lungs. So the use of high frequency also combined with less aggressive resuscitation, improve the lung volume at the delivery, and giving less invasive surfactant administration altogether, in our experience, have decreased or helped to decrease the higher risk of BPD. So probably these kind of things will help us at least to decrease damage of our babies. And we recommend the use of this high frequency ventilation with a volume guarantee when the lung situation of the baby is showing you that the trauma with the conventional ventilation probably is too high. So thank you very much for your attention. This is the second talk, and now I will be very open to answer your questions and talk with your comments. Thank you.